multiple papers have come out. Realistically, we are somewhere around 15 to 18% range post-SBRT fractures. And the more lytic the metastasis, the higher the chance of fracture. So post-SBRT, the patient's back pain increased quite a bit, had to take a lot of narcotic analgesia, was almost hyperalgesic with pain. And this is the CT of the patient post-SBRT. Didn't show much in terms of sclerosis, which is typically what's seen with the post-SBRT. And you can see not much height loss, but you can see it's completely lytic. There is some disruption of the superior end plate. So on this one, I decided that because this was post-SBRT, didn't look like SBRT had controlled the tumor as much, and I thought that maybe it will spread more. So better to go with V-STRUT here so that we could get into the pedicles also and at least augment the pedicles. One thing I will tell you is if someone really wants to get into V-STRUT and wants to, even for other implants also that you are doing, please make sure that wherever your practice is, that your surgeons are on board, because especially if you're doing tumor cases, you never know. You may get a great result post-procedure with tumors, but you never know with tumors what tumor is going to do. And surgery is always an option with tumor that should be on the plate and is a realistic possibility. So your neurosurgeon has to be on board with all the implants that we are starting to put in, and that's exactly what happened when whichever implant I use, I really talk with my surgeons if they are okay with that, and so that's one little side note. Okay, so after that we went in. Obviously, we ablated, did a bipedicular ablation of the cavity, and then we started to put the V-STRUT in. So as it was already alluded, that if you're doing it under conscious sedation, judicious use of local anesthetic. That is really the key. Periosteal injection is good. Make sure that you inject about 1 to 2 cc's in the periosteum all the way up and down the track. Your incision has to be quite big because that will help you to move your needle, your drill, whatever, in both medially, laterally when you have to change direction. And as I said, with this device, how you enter the vertebral body is pretty much it. You cannot change much with this device, especially if you're used to putting in spine jack. We know how much we can change the final position of the spine jack with the reamer as opposed to the drill that we used here. Once your wires go in, it's pretty much you just follow the wire, and that's how you will be in the vertebral body at that point. The other thing is that when you put the dilator in, you will have to use a lot of muscle power. Some people have very tough muscles, so be prepared to really push in that dilator over the wire. And in soft bones, especially with lytic metastasis, you have to be very, very careful when you are doing that. And so keep on looking at your wire, that your wire is not moving too much in the vertebral body, and hold your wire very, very firmly, especially in lytic lesions. So once you get in, then pretty much wires are in, and then you just follow the wires. So you will have both a pre-drill as well as your implant drill available in your set. If I am doing a hard bone, I will use a pre-drill. If I'm using a lytic metastasis, I don't have to use a pre-drill. I'll go straight with the implant drill because it's so soft in there. So you can straight away go only once with that. But in a hard bone, definitely a pre-drill will help you a lot. And so this is now the cement going in from one side and the other side, and we had a pretty good feel, and you can see the implant on both sides. And this is the CT, as we already showed that the implant has to sit right on the pedicle, the back end of the implant, and the patient had good relief after the procedure, and did pretty well actually with a pain VAS score of about I think it's about 3 at about 2 months now. So that's pretty good. This is a case I just did yesterday. Another tumor, metastatic. You can see it's involving the posterior half of the vertebral body, and it's extending into the pedicle, ipsilateral pedicle right there. So we went in, we did, this is just like the case which Matthew just showed. So we went into the pedicle, ablated the pedicle, stayed on the ipsilateral half of the vertebra, did the pedicle, and then as it was coming into the pedicle, so it was always good to put the V-STRUT in, because that, in my favor, when you're doing tumors, I think that's one of the biggest advantages you get with the strut, is that if the pedicle is involved, or if the tumor is very close to the pedicle, you augment the pedicle with the strut. That's definitely going to be beneficial for the patient, especially because we do a lot of diffusely metastatic disease where we do not want to ablate the vertebral body, and so obviously whatever we do, even ablation, the first aim is pain palliation, and the second one in oligometastatic disease is local regional control. But if it's diffusely metastatic, you want to do and you know that the patient is not going to go for surgery, then this is a great piece of instrument that you can use in such patients when you know it's coming closer to the pedicle. So here you can see again, we went in with and the fill was really good. I was very happy with the fill that we got in this patient. Again, we had a little bit of a paraspinal extravasation there, but here you can see the CT that we got right after the procedure. I just wanted to see the fill, and that's the little extrava in the paraspinal region, but really good fill. Previously, if I was doing this case, I would have done a pediculoplasty, but now with this, I really do not want to do a pediculoplasty as we have the strut nicely in place. This is another case, and now you have seen multiple examples of this. This is the first case that if you're go in all the way anterior, I think that's very important, so that you will measure out the correct length of the strut that you're going to use. Again, as I said initially, I really like to go in a vertebra. If I'm not targeting a tumor, I really like to go in the mid portion of the vertebral body, just because the cement comes out up below and from the side. So that's probably a good point to keep in mind. The one more thing I wanted to touch on is, because we saw some cement extrav into the disc. I don't know what your threshold is when you get extravasation in the disc to do the adjacent level prophylactically. For me, if I get 50% of my cement gets into, I mean, the volume of the disc is filled up by 50% cement, I will do the adjacent level prophylactically, because that really puts your adjacent level at risk. If it is less than that, then I really do not want to do the adjacent level. So that's my threshold, and that's what I always look for. How much cement has gone into the, obviously you don't want that much cement going into the disc, but again, the tumors, it happens more frequently than it happens in osteoporosis. So here we again drilling, putting the struts in. You can see the anterior aspect. You will have those two radio-opaque markers. There will be the radio-opaque markers on the back end. This is the AP view, and then you start filling them. What I really love about this is the circumferential fill, and I think that's one of the hallmark of this. Is the circumferential fill, and it really fills up the vertebral body quite nicely, both in transverse as well as in AP dimension. So that and as people have already alluded to, we have done probably close to 20, 22 cases now. I have yet to see an adjacent level fracture. And at some point, that is something that we need to publish with this, because I think if this holds for 6 months to a year, that is definitely a big thing with the adjacent level fracture and should be published 100%. And I was glad to hear all the speakers talk about that they have not seen adjacent level fractures so far with the use of this device, which is something to just keep in mind. This is just technique of these cases here. We are seeing these implants, and the two implants have now gone in. So you want to see the distal end of the implant outside of your dilator and the tube. And that's when you know that you are right in place and you're sitting on top of the pedicle when you see the back end of the tube like that. And then you start putting the cement in. And so this was a spine jack that was done at the lower level, and you can see the difference, how beautifully V-strut cement has spread all across the vertebral body at that level. So of course, we do get all these extravs within the paraspinal veins and all that. You have to keep a lookout for whether it is propagating or not. But overall, I'm very happy with this device, be it for tumors, be it for osteoporosis. And I think people who start to do it at first may get a little bit overwhelmed with the steps. I'm at a teaching institute, so I have fellows with me all the time who are doing it. So honestly, it takes me a little longer because I barely get to touch the needles. But I can tell you that some of the fellows initially, when they started to do the first, second case, they were a little overwhelmed with the number of steps, with the instruments that are being used. But once you get used to it, it's fast. You can do this case in like 30 to 40 minutes tops, easily. And uh, the response, patients, VAS scores, I have yet to see a patient that did not have an improvement in the pain score after this, did not have improvement in the quality of life after we use this device. So all the post parameters that we check for are really great with this device. So, and I hope that it remains like this, because the in the immediate post-op, it's all looking great. We have had patients up to 3 months that we are watching, but as we go more 6 months to a year, and especially see the adjacent level fracture, that'll be a big deal for this device. Thank you. You muted. Cecil, you're muted. We can't hear you.
Thank you very much, Dr. Khan.
Oh.
I was asking, any questions from the audience?
Hi, this is Rakesh. I am one of the newer partners of Dr. Mitchell. Just reviewing some of these things as a troubleshooting technique, like let's say if the strut itself is not moving forward exactly in the vertebral body. I mean, with the spine jack, they say if it's not expanding, you can still fill the cement and you're going to be fine. But if the strut is not moving forward, what can you do?
What is not moving forward? Sorry.
The implant is not like pushing through into the vertebral body, like part of the implant is outside.
Oh, the implant is not moving forward.
Yeah.
I guess you put the wire back in and you drill back again. That'll be the easiest solution, because that means your track is not good. That's why your implant is not moving forward. So just put the wire back in and start drilling back again.
But can you pull the implant back, like out, so that you can drill more? Or
Yeah. Oh, yeah. Absolutely. The implant is very tightly screwed to this the T-bar that you are seeing right there in the middle. So it's very tightly screwed to it. So as long as you have not unscrewed the implant, you can pull it back.
And I
see.
have tapped these in a little bit. That works okay. If you do that too much, though, you'll actually force some bone fragments into through the little side holes. So I like the idea of taking the implant out and using the drill again. I think that's a better way to do it.
Thank you.
I just have a quick question. Hi, this is Paul Kolopus from Hershey. So how do you select your patient? Maybe I missed the prior two webinars, so maybe it was covered there. But which patients do you select for the V-STRUT procedure as opposed to all the others that are available?
Someone wants to
For
go
me,
first, then.
So for me, it's been until the new devices that's been released, the smaller device, it was really limited to pedicle size. I get some elderly female patients, they have smaller pedicles, particularly at the thoracolumbar junction. So having to have a 5.5 millimeter pedicle was what has been somewhat a limiting factor. I think we can overcome that now with the smaller device. But
So you don't look for a pedicle fracture necessarily.
no, I'm looking to use this to prevent adjacent level fractures in addition to a pedicle fracture.
Okay.
Yeah.
Thank you. Thanks.
Basically, your FDA approval is for any osteoporotic fractures, so you don't have to really look for any particular type of a fracture for this device. Cecile, is pathological fractures now FDA approved also?
Yes.
Okay, so there you go. So you have both FDA approval for pathological as well as osteoporotic fractures. For me personally, if I'm using it for pathological fracture, and if there is anything is close to the pedicle, I'll use this. If I am trying to go for height restoration, I will still use spine jack. But otherwise, you can use it for any fracture. And as they said that the adjacent level fracture incidence is negligible to extremely low, so that's a big plus.